Definitions and targets for hypertension, changing goal posts. I'd like to invite Dr. Pankaj Manoria. He is a Chief Intervention Cardiologist at Manoria Heart and Critical Care Hospital from Bhopal, Madhya Pradesh for the next 12 minutes plus 3 minutes for discussion.
I think it's a proud privilege for anybody to be called as a faculty in his own alma mater. And I'm extremely thankful to the organizing committee of UPCSI for that. Now coming back to the topic, definitions and target of hypertension, changing goalpost. It's a very interesting topic with a catchy title, and rightly so, because if you see, hypertension or high blood pressure in older days was considered necessary and essential for the perfusion of the vital organs. And from that era, the definition and target of hypertension has moved to the present era in which even 130 by 80, more than 130 by 80 blood pressure is termed as stage 1 hypertension. If you go to the history of hypertension, the Professor Paul White in 1931 said, hypertension may be an important compensatory mechanism which should not be tempered with even what it's certain that we could control it. In the British Medical Journal 1931, an article was written which said that the greatest danger to a man with high blood pressure lies in its discovery, because then some fool certainly will try to reduce it. In the text of 1946 textbook of heart said that people with mild benign hypertension with a blood pressure of 210 by 110 need not be treated. And there's a psychopathologic personality associated with hypertension. So those were the era. So you can see how the goalpost of target and hypertension from that era, which I can say the goalpost was lying even outside the ground. In that era, it was not considered even a disease, high blood pressure. Now, you'll be surprised as to why I have put this picture of famous Yalta conference during the World War II in this my lecture of hypertension. Because it has a great reference as far as revolution of treatment of hypertension was concerned. If you look at the three famous personalities in this picture, on my left was Winston Churchill, the Prime Minister of, at that time, of the UK. On my extreme right was Joseph Stalin, Soviet Union President, and in the center was Franklin D. Roosevelt, who was the President of the United States of America at that time. And all these famous personalities after the World War, they died of hypertension and its consequences. In fact, after that of USA President Franklin D. Roosevelt, who died of the cerebral hemorrhage with a blood pressure of almost 250 by 160, the United States government realized that high blood pressure is dangerous and it's time to study the effect of high blood pressure. And they raised, and after his death, they raised the funds for the famous Framingham heart study, which found a strong correlation with high blood pressure, hypertension, with stroke, kidney disease, and heart failure. Then in 1964, the famous veteran administrative studies began, and this study told us that the high diastolic blood pressure of 105 or more can lead to serious consequences. And in 1977, the first JNC, Joint National Committee of Prevention Hypertension, was formed. And in JNC 1 also, they didn't mention anything about systolic blood pressure. They only said that diastolic hypertension above 105 should be treated. There was no mention of systolic blood pressure in JNC 1. In JNC 3, they realized that systolic blood pressure is also important, and they said that beyond 160 millimeter of systolic blood pressure, you should treat systolic blood pressure. So if you see the timeline of JNC, the first JNC, no mention of systolic blood pressure, only diastolic blood pressure of more than 105 should be treated. JNC 3, systolic blood pressure more than 160 should be treated. And then in JNC 5, they say more than 140 millimeter of mercury is hypertension and should be treated. And JNC 8, again they switched that they said if the age is more than 60, a blood pressure should not be lowered to less than 150. There's again a twist in the tail with JNC 8. But this JNC 8 recommendation of not reducing the blood pressure to less than 150 was strongly criticized to the fact, but because immediately after that, the INVEST trial which was conducted, which clearly showed that compared to the blood pressure of less than 140, those with a blood pressure of 140 to 150 had a 34% more chance of cardiovascular mortality and 81% more chance of stroke. So thus, following JNC 8 recommendation of not lowering blood pressure to less than 150, we may increase the risk of stroke and CV mortality. So this recommendation was almost rejected by majority of members of the panel. And then came the sprint trial, again, which again was again a revolution trial as far as management of hypertension was concerned. In this trial, there was two arms, one with a very intense arm with a target blood pressure of less than 120 by 80, and second was a modest arm with a target systolic blood pressure of less than 140. Almost more than 10,000 patients were studied, and what they found was if the target blood pressure is very intensely controlled, means less than 120, the chance of major adverse cardiac event was significantly reduced. So based on this sprint trial, the ACC AHA recommendation of 2007 guidelines, they make the 130 the new 140, meaning 130 by 80, beyond 130 by 80 will be termed as hypertension and not 140 by 80, 190. So this 130 was the new 140. So they changed the terminology from pre-hypertension, which was seen in JNC 7 between 130 to 139 blood pressure, to stage 1 hypertension. So why did they do so? They did that because they found that if you compare the chance of events in the population between normal blood pressure versus 130 by 139, there were almost 2 to 3 times more chance of event in that subgroup of population. So if you change the terminology from pre-hypertension to hypertension, it will heighten awareness and it will create more positive from the patient to adopt a healthy lifestyle. This was the main intention of ACC, to change the terminology of blood pressure 130 to 139, not calling as pre-hypertension, but calling as stage 1 hypertension, to increase that awareness. But what happened as, suddenly when the definition of hypertension was changed, in USA, the prevalence of hypertension changed from 72.2 million adults to 103.3 million adults in a single day. So again, there was a lot of criticism that is it evidence-based medicine or there is any conflict of interest. But if you look at the recommendation of ACC, clearly they said you can call them a stage 1 hypertension between BP of 130 by 139, but you do not start pharmacotherapy in all these patients. You have to start drug treatment only and only if these patients are high risk and they have a chance of event in the near future of more than 10%. Otherwise, you may advise them healthy lifestyle. So actually, though the prevalence of hypertension increased by changing the definition, but actually additional pharmacotherapy which was required in these patients increased by only 4.2 million. The Europeans also did not fall behind. The 1 year after the ACC recommendation, the ESC recommendation of hypertension also came up, and they again said between 130 to 139, we are not going to call them hypertension, we are going to call them high normal. Again, they were against that terminology. The rest was almost the same. But again, they say, but both USA and European, they agree to the common point. Though the terminologies were different, they say between 130 to 139, you may not start therapy, but you can start therapy if the patient is high risk, having high chance of event. So ultimately, the motive of both were same, the terminologies were different. Even there was a lot of, in the last 1 decade, there was a flood of guidelines. The NICE guidelines, the CHEP guidelines, the American Diabetic Association guidelines, ISH guidelines. So different guidelines gave different recommendations depending upon the subset of population, whether it's diabetic, kidney disease, proteinuria, with or without proteinuria. There was a lot of confusion, you can say. Too many cooks spoiled the broth. So I can say this was an evidence-based confusion was created. But finally, the AHA, they have come to a common target. They have a national BP target, they say. You have to we have to keep the target of blood pressure 130 by 80, irrespective of everything. Whether the age is more than 60 or less than 60, whether it's diabetic, whether it's kidney disease, heart failure, ischemic stroke, irrespective of everything, you can see the target blood pressure is less than 130 by 80. So there's no confusion left as far as AHA recommendation is concerned. Even the European also agreed to that point, but they follow the two-step approach. They say first target should be less than 140 by 90. If the patient is tolerating well, then you further reduce the target to 130 by 80, but never reduce the blood pressure to less than 120. So target was almost the same, irrespective of everything. So just you could look how the goalposts have changed in the previous days to JNC third recommendation of 160 to 150, then 140, and to the present recommendation of 130. This is how the definition and targets have changed. The goalposts kept on changing. So if you summarize my, my lecture, I can say the target blood pressure is less than 130 by 80 in almost all the patients. More than 140 by 90, only the drugs are recommended. Between 130 to 139, you may call as stage 1 hypertension, you may call as high normal, you may call as mild hypertension, you may call as pre-hypertension, but treatment, pharmacotherapy is required only if the patient is high risk. Otherwise, the management remains the same. So having said everything, are we following BP guidelines? The rule of 50 still is valid in present scenario because out of all the hypertension patients, only 50% are aware they are hypertensive. And of the 50% who are aware that they are hypertensive, only 50% are taking treatment. And out of the 50% who are taking treatment, only 50% have their blood pressure under control. So we are fighting in the closed AC room for the mere blood pressure of 5 to 10. But actually the battle of hypertension should be fought even outside the room in the real world by public media, by public-private partnerships, including awareness through the media, mass screening of program, public health policies. It's a big problem. With all these things, by following all these things, we can control the menace of hypertension. Otherwise, very difficult to control the hypertension. Thank you again, UPCSI, and greetings from Bhopal, the city of lakes.
Okay, we'll now move ahead for the discussions. Thank you.
Thank you very much for wonderful lecture. Any questions from audience?
Any recommendation for isolated systolic hypertension?
They say, again, the recommendation remains the same. If the blood pressure is more than 140 by 90, you have to treat
Sometimes
irrespective of diastolic blood pressure.
BP of 170 by 70.
Irrespective of diastolic blood pressure. If the systolic blood pressure is more than 140 by 90, you need to treat pharmacologically.
Irrespective of low diastolic.
Between 130 to 139 depends upon the subset of patients.
Dr. Pankaj,
Yes.
the females when they come with eclampsia of condition, they have hypertension. So there are some different opinion, there are certain thought that in these ladies, you should not push up the blood pressure very down. So what do you say, what is the limit that when you start treating patients with eclampsia of pregnancy and hypertension?
Even in eclampsia, I can say if blood pressure is more than 140 by 90, you need to treat them. You have to keep the target less than 130 by 80, even in patients with pregnant women.
I say there is a difference of opinion. In eclampsia of pregnancy, they say this is also important for the fetus to get the full supply. And therefore, those hard indications of reducing BP to less than 140/90 probably is not holding true in that setting.
I agree with Professor R.P.S. Bhardwaj that to start the drug therapy in a pregnancy who is not a known case, you have to a higher threshold, more than 160 by 95 or 105. There is a different guideline for different. But who is a known hypertensive and taking treatment, you have to control blood pressure and make it lower.
No hypoglycemia or no B12 deficiency. What's your take? Is it significant and what should be done?
So please, what's the blood pressure?
105, 102 upon 70. Lower range.
Lower hypertension you are speaking about.
Yes.
And he's already on antihypertensive therapy.
No, normal. But having dizziness and
I think then you need to evaluate what is the cause of hypertension in this patient. Then you can give, we have multiple drugs. We have midodrine available to increase the blood pressure. We have fluorocortisone available to increase the blood pressure, depending upon the symptom of the condition, the cause of the hypertension.
So you have experience with the fluorocortisone?
Fluorocortisone, we have midodrine alpha-1 agonist also available now, which can be used if there is a symptomatic hypertension.
These are the patients which is normotensive, not hypotensive.
But they have
if the
symptoms.
patient, no.
Okay,
There are some other causes, maybe.
We need to evaluate exactly.
Yeah,
We should not treat the hypotension. No, this is normotensive. The guideline says less than 130 by 80. All are normotensive patients. It can be 116 by 70, 120 by 70, even 100 by 70. If the patient is asymptomatic, if the patient is dizzy, then we should, we should evaluate, not just treat the hypotension. We should evaluate fully what is the cause of this dizziness.
That's the time that we have.
Hypotension
Mr.
is
Chairman.
not the only
We'll
cause
have
of
to move on to the next
dizziness.
presentation. Thank you, Dr. Manoria. With the permission of the chair, we move on to the last presentation of this session. That's on cardiometabolic syndrome, novel therapeutic approaches.